afternoon everyone. My name is Dr. Abhay Pota. I am assistant professor in pediatric cardiology. We will be discussing today about understanding congenital heart disease, a primer on key concepts and terms. So we will be focusing on certain terminologies and concepts which are key to understanding of congenital heart disease. We will be discussing about anatomical terminologies and concepts, physiological terminologies and concepts, and certain common eponymous surgeries which are named after so and so persons. First of all, cardiac position. So there are two different things. One is position and one is cardia. Position of the heart in thorax. If the heart is positioned on left hemithorax, it is called levo position. If it is in right hemithorax, it is called dextro position. If it is midline, then it is called meso position. While this is position of heart, orientation of cardiac apex that is determined by base apex relationship of heart. So levocardia means that heart is oriented with base of heart is at right shoulder and towards left anterosuperior spine, apex is there. The inverse of that is dextrocardia, that is base is on left side and apex is on right side, and midline heart is mesocardia. Next is situs. All major organs begin their embryonic development as midline structures with bilateral mirror image symmetry and later develop asymmetry, and hence they have laterality or sidedness. This laterality or sidedness is basically situs. Situs means sidedness. So there are three types of situs are possible: cardiac situs, pulmonary situs, and abdominal situs. For example, cardiac situs means cardiac structures are not bilaterally symmetrical, they are asymmetrical. Pulmonary situs and abdominal situs also mean that their structures are not bilaterally symmetrical. Examples of pulmonary and abdominal situs. Pulmonary situs means that left lung has 2 lobes while right lung has 3 lobes. Left bronchus is more horizontal than right bronchus, which is nearly vertical. Abdominal situs means that stomach is on left side, spleen is on left side, while the liver is on right side. This basically indicates laterality or sidedness of different structures. There is asymmetry is there. If this asymmetry is not there and there is symmetry, then it is not normal. So visceroatrial situs. Visceroatrial situs is relationship between viscera and atria. Relationship between viscera and atria. Situs is, as we have discussed, sidedness or site or position of the viscera and or atria. What is situs solitus? Solitus means normal or usual. Situs solitus means normal sidedness or normal site, normal position. Normal arrangement of viscera, atria, that is RA on right side, LA on left side. That is cardiac situs. What is situs inversus? Situs inversus means that stomach is on right side, liver is on left side. Same, the pulmonary situs is also inverted. Left lung is trilobed and right lung is bilobed. Left bronchus is more vertical than right bronchus. That is situs inversus. What is situs ambiguous? Situs ambiguous or heterotaxy, they are nearly synonymous terms. So what is heterotaxy? Heterotaxy is, in Greek, heteros means different and taxis means arrangement. So different arrangement than usual is called heterotaxy. We have already seen that what is the usual arrangement. Usual arrangement of bronchus, usual arrangement of lung, usual arrangement of abdominal viscera, and usual arrangement in heart. Anything different than this is heterotaxy. Then there is a certain term called isomerism. In Greek, isos means equal and meros means part. The similarity of bilateral structure that are normally dissimilar. If they are similar, so if they lose their asymmetry, that again means isomerism. So visceral heterotaxy or situs ambiguous are synonymous terms. Internal thoracoabdominal organs demonstrate abnormal arrangement across the left-right axis of the body. Left and right isomerism, they are a variant of heterotaxy syndrome. So basically they are part of heterotaxy syndrome in which some paired structures on opposite side of the left-right axis of the body are symmetrical mirror images of each other and have the morphology of the normal left or right-sided structures. So as we can see in this image, what is situs solitus, that we already discussed. Situs inversus we have discussed. What is asplenia and polysplenia? They are basically types of heterotaxy. Asplenia means there is right isomerism. Right isomerism means right sided structures are there on right side as well as left side. So there are two lungs, both are trilobed, right and left side. Both bronchi are nearly vertical on right and left side. Liver is there in midline and nearly extending to right and left both sides. Stomach is also in midline. And spleen, there is spleen is absent because it is a left-sided structure and there is right isomerism. Right-sided structures are getting similar on both sides, so there is absence of spleen is there. That is called asplenia. Then what is polysplenia? Polysplenia means left-sided structures are there on both sides. Left lung is there on left side as well as right lung also becomes like left lung. Bilobed, both lungs are bilobed, nearly horizontal orientation of bronchus in both the lungs. Again, liver and stomach are midline structures, and there are basically spleen is a left-sided structure, so there are multiple spleens. So what is asplenia? It is right isomerism. Right-sided structures are there on both the sides. Polysplenia, left-sided structures are there on both sides. Right isomerism is commonly associated with TAPVC, that is more commonly extracardiac TAPVC, that is either supracardiac or infracardiac TAPVC. Next is common AV valve, DORV, pulmonary atresia. These are the common associations in right isomerism. Also commonly LSVC can be seen draining directly into LA. While in polysplenia, most common association is there is interrupted IVC. IVC interruption is seen in nearly 90% cases of polysplenia. That is left isomerism. Again, IVC is draining into right-sided RA. That is a right-sided structure. So in case of left isomerism, it is expected that IVC can get absent. So next is AV and VA concordance and discordance. So basically in Latin, concordare means is to agree. So concordant and discordant AV connections, morphologically right atrium connects to morphologically right ventricle, and the morphological left atrium connects to morphologic left ventricle. RA is connecting to RV and LA is connecting to LV. That is called concordant AV connection. What is discordant AV connection? As we can see here, RA is getting connected to RV, that is AV concordance. LA and A is getting connected to LV. While in this picture, RA is connected to LV and LA is connected to RV, that is AV discordance. Same way for VA connections also, LV is connected to aorta normally and RV is connected to pulmonary artery. There is one more important term here is that LV is connected to aorta or its remnant and the RV is connected to pulmonary trunk or its remnant. So there can be pulmonary atresia as well, but still it is getting connected to pulmonary trunk only, despite pulmonary atresia being there. So now the thing is that normally LV is connected to aorta, RV is connected to pulmonary artery, that is VA concordance. What is VA discordance? LV is connected to pulmonary artery and RV is connected to aorta. As we can recall, this is called transposition of great arteries. What are the other types of AV connections that can occur? AV concordance, that we have already seen. AV discordance can be there. Then there can be double inlet. What is double inlet left ventricle? Double inlet right ventricle or double inlet left ventricle? More commonly double inlet left ventricle. It is a more common anomaly. So any congenital heart disease with a univentricular atrioventricular connection, wherein both atria connect to a morphological left ventricle either via two separate atrioventricular valves or a common atrioventricular valve. So either via two separate atrioventricular valves or via a common atrioventricular valve. These both are examples of double inlet left ventricle. Then this is single inlet, that is univentricular circulation, single inlet connection. What is single inlet? This is case of tricuspid atresia. LA is connected to LV via this valve, while there is tricuspid valve is absent. Next is overriding. What is overriding of AV valve? Overriding is basically valve annulus lies in part above both the right and left ventricle. Normally AV valve annulus lies right avival annulus lies above right ventricle, left avival annulus lies above left ventricle. But when there is overriding is there, it lies in part above both right and left ventricle. A single annulus lies above both. So this is normal. RA connected via right avival annulus to RV, LA connected to LV via left avival annulus. Now there is overriding is there in this case. So there is what is overriding? Overriding is basically what is there, that annulus is overriding above this interventricular septum. This is interventricular septum. As we can see, this valve is overriding. Next, there is even more overriding, and now it has totally committed to LV. So with progressive leftward shifting of this valve, or we can say interatrial septum, as the interatrial septum is moving toward left, or the annulus is moving towards left, we can see that initially it was totally normal AV connection, then it became a bit of overriding, then overriding even more increased, and then now this is totally DILV, a case of double inlet left ventricle. So basically, with progressive overriding of right AV valve, connection changes from concordant to DILV. What is this 50% rule? 50% rule states that AV valve annulus which is overriding more than 50% to whatever ventricle is it constitutes that it is joining it. So for example, if right AV valve annulus is overriding above this interventricular septum more than 50%, it is taken that this is RA is draining into LV and not into RV. If it is less than 50%, then we can say that though overriding is there, RA is mainly draining into RV and not into LV. Next is ventricles. What is a ventricle basically? So any chamber receiving more than 50% of the inlet part. So there are certain terminologies related to ventricles. Few have characterized ventricle as having two parts. One is sinus and one is outflow part. Some have characterized them having three parts. One is inlet, trabecular and outlet. So any chamber which is having a inflow part, that is inlet or sinus part, is called ventricle. A ventricle cannot be there without sinus or inlet or inflow part. So then what is rudimentary chamber? Rudimentary chamber is having inlet, but it is receiving less than 50% of inlet. Inlet is very less developed. What is outlet chamber? Outlet chamber is basically rudimentary chamber consisting of an outlet portion only. So it is not a ventricle. Trabecular pouch, those possessing only a trabecular or muscular zone. So there can be a ventricle which has got inlet, trabecular and outlet. A rudimentary chamber which has got inlet but very less developed inlet part, outlet chamber which has got only outlet, and trabecular pouch which has got only trabecular portion. Then what is D-looping and L-looping of ventricles? D-looping basically means that RV, or as we already discussed, precisely RV sinus or RV inlet is on the right relative to LV, that is normal. Our RV is on the right of LV, that is normal, that is D-looping. What is these D and L looping have embryological connotation, but we can discuss it separately later. What is L looping? L looping is RV is on the left of LV. Say for example in CTGA. In CCTGA, completely corrected transposition of great arteries, there is LV is on the right while RV is on the left in case of situs solitus CCTGA. What is aortomitral fibrous continuity? Direct fibrous continuity exists between the AMVL and left and non-coronary cuffs. These muscle bundle causes appreciable valvular separation, as is often seen in a case of double outlet right ventricle. This valvular separation should be considered significant when it is more than 3 mm on echocardiography, and then it should be called aortomitral fibrous discontinuity. This indicates presence of subaortic conus muscle. This is the embryologic basis of aortomitral fibrous continuity. Then coming to VA connections. VA connections, as we have already seen, they can be concordant, that is RV is giving connected to PA, LV connected to aorta, and discordant, that is RV is connected to aorta and LV is connected to PA. Then two other types of VA connections are possible. One is double outlet. This is example of double outlet right ventricle. What is double outlet right ventricle? Both great arteries arise entirely or predominantly from the morphological right ventricle. Then DOLV, that is double outlet left ventricle. What is double outlet left ventricle? Both great arteries arise entirely or predominantly from the morphological left ventricle. Why this morphological word is important? Morphological left ventricle means that it is not about where is the ventricle. The ventricle on the left side is not left ventricle. It should be morphological left ventricle. So this left ventricle can very well be on the right side also, but it is left ventricle based on its morphology. Then there can be common outlet, that is common arterial trunk, or as commonly known as truncus arteriosus. A single arterial trunk arises from the heart, giving origin sequentially to the coronary arteries, one or more pulmonary arteries in the systemic arterial circulation. Again, overriding can be seen in semilunar valves also, and again we can see in semilunar valve that with progressive rightward shifting of outlet septum or overriding of aortic valve, connection changes from concordant to DORV. We have previously seen that connection changes from concordant to DILV with progressive leftward shifting of interatrial septum or right AV valve annulus, while here in cases of VA ventricular arterial connections, there is with progressive rightward shifting we can see that connection is changing from concordant to DORV, and same here 50% overriding rule also applies. Next is straddling. So straddling, what is straddling? Straddling is that subvalvular apparatus has attachments within both ventricles. So what is this subvalvular apparatus? Mainly chordae. So there are three types. If chordae are attached on interventricular septum tip, then it is type A. If they are attached on interventricular septum on other side, then it is called type B, and if they are attached to free wall, then it is called type C, straddling. This is only seen in cases of AV valves and not in case of semilunar valves, as they have no chordal apparatus. Next is, what is NRGA? Normally related great arteries. Normally related great arteries, as can be seen in this middle picture, that aorta is central and PA is left and anterior. This is anterior, this is posterior. This is left, this is right. So aorta is central, PA is left and anterior. That is normal related great arteries. Then what is deposed aorta? Deposed aorta is this. Aorta is here and this is PA. So PA is left and posterior to aorta. PA is left and posterior. What is L-post aorta? Is this. Aorta is here, this is PA. Aorta is left and anterior while PA is right and posterior. This is called L-post aorta. Important thing is that on echo we comment on relationship of great arteries at the level of valves. As we can see here, these are the valves. We comment on great arterial relationships based on their relationship with each other at the level of valves. Then there are multiple other combinations are possible, like side by side great arteries and others. They are called malpost great vessels. So this is normal related great arteries, deposed aorta, L-post aorta. If there are other relationships are there, then it is called malpost great vessels. Now important thing is that D and L-post aorta do not necessarily mean diagnosis is D or CCTGA and vice versa. So if there is deposed aorta, it does not mean that diagnosis is DTGA, or L-post aorta is there, then diagnosis is CCTGA. While at the same time, it can be very well be possible that a TGA case may not have D malpost great arteries, or CCTGA case may not have L malpost great arteries. Then there is certain terminology called ACMGA, that is anatomically corrected malposition of great arteries. That means two things: anatomically corrected and malpost great arteries. So first is great arteries are malpost, but despite their malposition, each great artery nonetheless arises above the anatomically correct ventricle. So RV to PA and LV to aorta. So consequently, anatomically corrected malpositioned great arteries means ventriculo-arterial concordance. Now commonly what we use the terms like LVOT and RVOT, left ventricular outflow tract and right ventricular outflow tract. What are these things? What is left ventricular outflow tract? What is right ventricular outflow tract? So here, as we can see in this picture, this is a picture of LV. from LV, taken from LV free wall side. So here this component 1 is atrioventricular canal, this is mitral valve. This is component 2 is finely trabeculated LV sinus, this is LV sinus or LV body. Component 3, this component 3 is smooth superior component of intraventricular septum, and this is regarded as proximal portion of conus, this is proximal conus. Component 4 is distal diminutive subsemilunar conal septum. So as we have a little bit of misconception about conus, that it is only there below in right ventricle, but it is also there in left ventricle, but it is very diminutive. So this is left ventricular conus. So now components 1 and 2, these component 1 and 2 make for left ventricular inflow tract or inlet, this is the inlet part of left ventricle. Components 3 and 4, component 3 and 4 along with anterior mitral valve leaflet, this is anterior mitral valve leaflet, make up for the left ventricular outflow tract or outlet. So this one is the left ventricular outflow tract. Next, in case of RV, this one is RV. So component 1 is atrioventricular canal, this one is tricuspid valve, this one is atrioventricular canal. Component 2, this one is component 2 is RV sinus or body, RV sinus or body. Component 3, this is septal band, this one is septal band, this one is moderator band, this is moderator band, this is septal band. Component 4 is conal septum and parietal band, this one is conal septum and parietal band. So now components 1 and 2 make up for right ventricular inflow tract or inlet, 1 and 2. So this one is inlet or inflow tract, RV inflow tract. Component 3 and 4, they make up for conus infundibular RV outflow tract or outlet. So they go by multiple names, but what we mean when we say that RV outflow tract is basically this much part. This is RV outflow tract. Then there are two terms like conus and infundibulum. What is conus? What is infundibulum? Infundibulum basically means funnel in Latin, this being the inside appearance of the RVOT. It is the inside appearance of the RVOT. While conus means in Latin that this being the outside appearance of the RVOT. That is outside appearance of RVOT. So this is why infundibulum has more of an anatomical connotation, whereas conus has more of an embryologic connotation. But both terms are used as synonyms. So conus and infundibulum nearly mean the same thing. This is the picture of anterior deviation of conal septum. This one is aortic valve, this one is conal septum. This one is aortic valve, this one is conal septum. So this is RVOT, this is RVOT. Tricuspid RA, tricuspid valve, RVOT, pulmonary valve. So there is anterior, this is anterior, this is posterior, anterior, posterior, anterior, posterior. So this conal septum, instead of being here or instead of being like continuing like this, has moved anteriorly. This is anterior. So this conal septum has moved anteriorly. So it is obstructing here. This is anterior deviation of conal septum seen in case of TOF. So certain terminologies related to cases of pulmonary atresia intact ventricular septum. Monopartite RV, bipartite RV and tripartite RV. What do they mean? Monopartite RV means that there is only inlet component is there. Bipartite RV means that there is only inlet and outlet components are there. While tripartite RV means that inlet, trabecular and outlet, all three components are there. This is basically due to there is cavitary hypoplasia. This cavitary hypoplasia is due to muscular hypertrophy. All three ventricular components are present in all cases. Important thing is that the key to appropriate interpretation is recognition that the increasing muscular hypertrophy or mural hypertrophy squeezes out the different parts of the RV cavity, starting from trabecular and then outlet and lastly inlet. So this muscular hypertrophy, if it has squeezed out trabecular part, then the RV will be called bipartite RV. If it has squeezed out trabecular as well as outlet part and only inlet is remaining, then it will be called monopartite RV. Then second term is RV sinusoids. These sinusoids are basically fistulous communications from RV. Fistulous communications from RV. What are these? What is RVDCC? Right ventricular dependent coronary circulation. So in PIVS, there will be suprasystemic RV. So there is flow via ventricular-coronary arterial connections or RV sinusoids into the aorta during systole, and retrograde filling of RV from coronary arteries during diastole. So RV systolic pressures, high RV systolic pressures cause high shear stress to the coronary arterial walls, leading to coronary stenosis, and hence there will be RV dependent coronary circulation. So what does RV dependent coronary circulation means? It means that in certain circumstances, alteration of the balance of right ventricular systolic pressures can lead to myocardial infarction, because coronaries are getting filled up from RV systolic pressure. Hence, any right ventricular decompression procedure should be avoided whenever there is presence of RVDCC. So, like for example, in case of PIVS, we imagine coronaries during coronary angiography, and we find that there are multiple either coronary atresia or coronary stenosis are there. So we know that coronaries are mainly getting filled via right ventricle during systole. Now in that case, in case if we inadvertently perforate the RVOT, then RV pressures will go down. Then this once the RV pressures go down, coronary fillings will decrease, and hence myocardial infarction can occur. VSD, this is very important. What is a VSD? VSD is basically ventricular septal defect. So it is interventricular septal defect. There has to be two ventricles to call it a VSD. So there is a term called bulboventricular foramen. What is bulboventricular foramen? Bulboventricular foramen is not VSD. Bulboventricular foramen is a communication between the dominant ventricle and the accessory chamber. There are two ventricles are not there. VSD is basically interventricular septal defect, while here there is one dominant ventricle and there is accessory chamber. Hence it is not called VSD, it should be called bulboventricular foramen. Again, this term has embryological connotations. Bulboventricular foramen, it's a short term for basically infundibular left ventricular foramen when right ventricular sinus is absent, as in a single LV with infundibular outlet chamber. So basically, if there are two ventricles, it should be called VSD. If there is only one ventricle and another is just outlet chamber or trabecular pouch, it should be called bulboventricular foramen. This is the RV anatomy. This one is the inlet part. If any VSD is there, this should be called the inlet VSD. This whole is muscular part. So here this is posterior, this is anterior. So here there will be posterior muscular VSD. Here there will be apical muscular VSDs. Here there will be anterior muscular VSDs. Here, if it is occurring below pulmonary artery, it should be called subpulmonic VSD. And here this is between this subaortic area and inlet area. There is here lies the perimembranous area. So if VSD is there, it is called perimembranous VSD. So what are the other terms for these VSDs? Perimembranous VSD is also called infracrystal VSD. Subpulmonary VSD is also called outlet VSD, doubly committed VSD, subaortic VSD or supracrystal VSD. All these are basically similar terms or synonymous terms. Inlet VSD is also called AV canal type VSD, and muscular VSDs are also called trabecular VSDs. Terms related to VSD. One commonly used term in pediatric cardiology is rootability. What is rootability? Rootability means that ability to surgically create unobstructed pathway. Ability to surgically create unobstructed pathway by patch closure of VSD or tunneling through RV via VSD so that LV can be connected to aorta or PA. Again reading it, ability to surgically create unobstructed pathway by patch closure of VSD or tunneling through RV via VSD so that LV can be connected to aorta or PA. Our purpose is to connect LV to aorta or PA. This is mainly used in cases of DORV or TGA with VSD and PS lesions. Another similar term is non-committed or remote or non-rootable VSD. VSD is related to neither of the semilunar valves, being separated from both by considerable muscle. Various causes can be there for non-committed or remote VSD like inlet or apical VSD, anomalous caudal attachments or long outlet septum. Next term is common AV valve. So there are two similar terms, AV canal defect or AV septal defect. AV septal defect, atrioventricular septal defect is a more recent term. So any congenital heart disease where both atria connect to a common atrioventricular valve which characteristically has 4 or 5 leaflets plus a single annulus. The common valve may have 1 or 2 orifices depending on the absence or presence of fusion of the bridging leaflets. So basically 4 types of AVCD are possible: partial, transitional, intermediate and common. But the essential morphologic ingredient is a common atrioventricular junction. There are no intermediate or transitional arrangements morphologically. So when a tongue of valvular tissue joins together, the 2 leaflets of the common valve that bridge the ventricular septum, the effect is to produce separate orifices. Essence of ostium primum defect is that fused bridging leaflets are depressed into the ventricular cavity and also fused to the crest of IVS. So only ostium primum ASD is there. If they are fused to the septum primum, then only inlet VSD can be there. Also, there is no real cleft is there. We commonly write that cleft mitral valve or cleft left AV valve, but actually there is no real cleft. Left AV valve closes in trifoliate fashion. It normally closes in bifoliate fashion. Normally it closes in bifoliate fashion. Mitral valve closes bifoliate way. But here the left AV valve also closes trifoliate way like tricuspid valve. So any surgical maneuver, however, never produces an arrangement of leaflets for the newly constructed left AV valve that replicates the arrangement seen in normal mitral valve. This is very important to know, that it is, even after surgery, it is still not a normal left AV valve is not converted to normal mitral valve. This is was the very important concept, that essentially morphologic ingredient is a common atrioventricular junction in all 4 types of AV canal. So even in partial AV canal there is a common AV valve. In transitional AVCD or intermediate AVCD there is a common AV valve is there. Related terms to AVCD: atrioventricular septal defect or AVCD or AVSD with ventricular imbalance, unbalanced or balanced AVCD, a variant of AVCD with one ventricle significantly larger than the other. So the other one is hypoplastic. What is double outlet DORA? That is double outlet right atrium. DOLA, double outlet left atrium. So DORA and DOLA, these are basically commonly seen in cases of AV canal defects. In these cases there is septum secundum. Septum secundum is malaligned to right or left into right atrium or left atrium. So say for example, in case of double outlet right atrium, septum secundum is malaligned and it is protruding into LA. So it is causing restriction of pulmonary valve inflow, while at the same time this RA is draining into both via tricuspid valve into RV and via mitral valve into LV. So that is called double outlet right atrium. What is double outlet left atrium? Double outlet left atrium is that LA is emptying emptying into RV and LV both via tricuspid valve and mitral valve, while RA is being its outflow is getting restricted because of the malaligned septum secundum. What is TAPVD then? Total anomalous pulmonary venous drainage. We commonly have heard that there is a common term called TAPVC, total anomalous pulmonary venous connection. It is very common to know about TAPVC, but what is TAPVD? TAPVD means that normal pulmonary veins are draining into LA roof only. Normal pulmonary veins are draining into LA roof only, but there is septum primum malalignment. Septum primum is malaligned and hence these LA pulmonary veins are draining into LA to RA. Septum primum is getting malaligned. This malaligned septum primum defect is leading to TAPVD. So septum secundum malalignment defects are DORA and DOLA. Septum primum malalignment defect is TAPVD. Certain terminologies related to aortic arch, arch sidedness. What is left arch and right arch? Left arch is basically left arch passes over left main stem bronchus and the right arch passes over right main stem bronchus. What is interrupted arch? Interrupted arch is any congenital heart disease in which there is an absence of luminal continuity between ascending and descending aorta. What is vascular ring? Vascular ring is congenital vascular encirclement of esophagus and or trachea by anomalous or aberrant vessels. It can be of two types, complete and incomplete. Multiple causes of vascular ring can be there. Common one is double aortic arch. It causes complete encirclement of esophagus and trachea leading to obstructive symptoms. Hypoplasia of the aortic arch. What is hypoplastic arch? Is hypoplasia of the proximal or distal transverse arch or the aortic isthmus. The isthmus, what is isthmus by the way? Isthmus is arch between the left subclavian and insertion of the patent ductus arteriosus or ligamentum arteriosum. If the isthmus is called hypoplastic when its inner diameter is less than 40% of the diameter of the ascending aorta. That is 40% of diameter of the ascending aorta, less than 40%. Proximal transverse arch. What is proximal transverse arch? It is the arch between innominate and left carotid arteries. And what is distal transverse arch? It is arch between left carotid and subclavian arteries. So any arch between first and second branch is called proximal transverse arch, second and third branch is called distal transverse arch, and third branch and ligamentum arteriosum is called isthmus. So proximal transverse arch is said to be hypoplastic when its diameter is less than 60% of ascending aortic diameter, and distal transverse arch is said to be hypoplastic when its diameter is less than 50% of ascending aortic diameter. Next term is comoral diverticulum. What is comoral diverticulum? Comoral diverticulum is basically a protrusion, this dilated part. It is just initial dilated part of subclavian artery. It is a protrusion from the proximal descending aorta that is directed rightward or leftward behind the esophagus. This diverticulum connects to the right or left subclavian artery and right or left sided arterial ligament. So this is basically a protrusion or dilated part of proximal subclavian artery. What is sling? We have discussed about vascular ring. This one is sling. What is sling? So sling is seen commonly in case of LPA sling. So left pulmonary artery arises from right pulmonary artery instead of the pulmonary trunk. Normally LP arises from MPA, while here in case of LPA sling it arises from RPA. It courses towards the left lung between the esophagus and trachea. It courses towards the left lung between esophagus and trachea, and hence this trachea is getting compressed on side and back by this LPA and anteriorly from MPA. So it can lead to obstructive symptoms. What is circumflex aorta? Circumflex aorta is any aorta with, say for example, right aortic arch with left descending aorta, or left aortic arch with right descending aorta, and respective PDA on the side of descending aorta. What is cervical arch? Cervical arch is one where the transverse arch courses within the thoracic inlet or neck, also called as high aortic arch. Branch PA related terms. First is hemitruncus. This one is relatively obsolete term. Newer recent term is RPA from ascending aorta. So RPA arises from ascending aorta and LPA is continuing from main pulmonary artery. This is called hemitruncus or RPA from ascending aorta. What is non-confluent branch PS? So absence of luminal continuity between the right and left pulmonary arteries. That is called non-confluent branch PS. Normally MPA continues as RPA and LPA. If RPA and LPA are not confluent, they are not connected basically. So they are originating from, say for example, RPA is originating from right-sided PDA and LPA is originating from left-sided PDA. Then they are non-confluent. They are there. RPA and LPA are present, but they are not connected and not confluent. What is peripheral PS? Peripheral pulmonary artery narrowing or hypoplasia at or beyond the hilar bifurcation. So it is peripheral PS. So essentially it is distal peripheral pulmonary artery stenosis, commonly seen in case of neonates, and it can regress by 6 months of age. Other terms, other common anatomical terms like hypoplastic left heart syndrome. It is a spectrum of congenital cardiovascular malformations with normally aligned great arteries without a common atrioventricular junction, characterized by underdevelopment of the left heart with significant hypoplasia of the left ventricle, including atresia, stenosis, or hypoplasia of the aortic or mitral valve or both valves, and hypoplasia of the ascending aorta and aortic arch. Generally, VSD is not there. One more common terminology is juxtaposed atrial appendages. What is juxtaposed atrial appendages? Any congenital cardiac malformation in which the right atrial appendage extends from right atrium behind the great arteries to lie adjacent to the left atrial appendage. So, say for example, in case of left juxtaposed right atrial appendage, this means that right atrial appendage and left atrial appendage both are on the same side, that is on left side. Left juxtaposition of right atrial appendage is nearly 9 times more common than right juxtaposition of left atrial appendage. Lastly, what is crisscross heart? Crisscross heart is atrioventricular inflow vectors are approximately orthogonal or perpendicular, so also called as superior inferior ventricles. One more thing we have very commonly seen in pediatric cardiology is what we read is SDS or ILI or SDD, these kind of things in echo reports. So what this is basically based on 1-part 3-part notation system. Cardiac segments are the anatomical and developmental building blocks out of which all hearts, normal and abnormal, are made. So what are these building blocks? 3 main cardiac segments are there: atria, ventricles and great arteries, and 2 connecting cardiac segments are atrioventricular canal or junction and the infundibular or conus. So what is say for example SDS? These are the 3 letters. First letter denotes situs. This is visceroatrial situs. So say for example, there are 3 types of situs as we have already discussed: abdominal situs, pulmonary situs, cardiac situs. Say for example, all 3 are situs solitus, then this should be labeled S. If any one of them is ambiguous, then this should be labeled A. If so this is about situs. Next letter is for looping. D looping means that RV is on right of LV. This S is for again for normal situs, but this is for great vessel relationship. So this is for visceroatrial situs, this one is for looping, and this one ventricular looping, and this one is for great vessel relationship. So here S means that great vessels are normal related great vessels. Now next example is ILI. So this is normal. Our normal hearts have SDS, that is situs solitus, D loop ventricle and normal related great arteries. What is ILI? ILI means that situs is inversus. I is stands for inversus. L looping of ventricle, and this I is for inverted great arteries. So this one is case of situs inversus dextrocardia. This is a case of situs solitus levocardia, that is normal. Here also it is normal, but it is case of situs inversus dextrocardia. Now this is case, third one is situs is solitus D loop ventricle, which is also normal. This one is normal, this one is normal, but D post aorta. So D post aorta, as we already discussed, this is commonly seen in TGA. Not necessarily always, but commonly seen in case of TGA. So SDD indicates DTGA. What is SLL? Situs is solitus, normal, L looped ventricles. So RV is on left of LV, and L post aorta. This is commonly seen in cases of DILV. SDL, situs solitus, D loop ventricle, but L post aorta. Situs solitus, L loop ventricle, D post aorta. Situs solitus, D loop ventricle, X indicates that one of the valve is atretic, either aortic or pulmonary valve is atretic. Here ADX, X is for atresia, D is for D loop ventricle. What is A? A is for ambiguous. So situs can be either situs solitus or inversus or ambiguous. Ventricle looping can be either D looped or L looped, and great vessel relationship can be either NRGA or inversely related normal great vessels, D post aorta, L post aorta, or one of the valve can be atretic. So whenever we read these kind of terminologies, we should interpret it this way. Thank you.